pleased to introduce Dr. Amanda Wade as our next speaker, who's an infectious diseases physician at Bowen Health, including being director of the Liver Clinic, and is also a senior research fellow at the Burnet Institute. And she is going to help her eliminate Hep C, and also give us an update on for HIV, including PrEP. Thanks, Amanda.
Thank you, Kelly. That's fantastic. So I did prepare some slides. Would we be able to see them? They're just coming. Great. Fabulous. Ooh. So I'll first declare my conflicts of interest. So I have received funding from AbbVie for investigator-initiated research only. And the learning objectives today are really to outline to you the many ways HIV can be managed in general practice, but particularly focusing down on PrEP. And also some HIV epidemiology, because that helps us know the story of what we're trying to manage, and then hepatitis C in general practice. So before I begin, can I just ask who is familiar with the concept of PrEP? If I say that, could I have hands up? Oh, that's fantastic. And could you keep your hand up if you've prescribed PrEP? Oh, that is really good to know. Thank you. So we're going to start with HIV and HIV risk. And this is the number of notifications per annum in Australia of HIV cases for the last 30 years. And you can see the original spike of the epidemic. But then really from the early noughties, the notification rate per annum has really been much of a muchness of about 1,000 cases per year. And this has been despite there being significant health promotion and advertising about condoms, about NPEP and PEP, which I'll go on to talk about in just a moment, and also health promotion campaigns about the importance of getting testing. So despite all these efforts, the notification rate hasn't changed. And that's why we're all really excited about PrEP. So for those that don't know, PrEP is pre-exposure prophylaxis. And this is fixed-dose combination tenofovir and emtricitabine, the trade name for which is Truvada, and it's taken daily to prevent the acquisition of HIV. So it requires 7 days to become effective, and it was listed on the PBS in Australia in April 2018 for adults at medium to high risk of acquiring HIV and, critically, who have a negative HIV test. So we're going to talk about that as well. It's been written on the PBS such that any medical practitioner in the country can write a script for tenofovir emtricitabine, and 3 months of the drug can be dispensed per script. Now, it's obviously available at the STI clinic at Bowen Health, but in addition to that, every medical practitioner can prescribe it. Now, if tenofovir emtricitabine sounds familiar to you, it's because we also use that drug to treat HIV, but we use it in combination with other antiretrovirals as well, so not alone. And also tenofovir by itself is used to treat hepatitis B infection. So you may have some patients who have been on this drug for those reasons. So I just wanted to do a quick compare and contrast of PrEP and PEP, because acronyms that one is unfamiliar with are really unhelpful. So PrEP we've just described, it's 1 tablet orally daily, and if we were to liken this to the analogy of pregnancy and contraception, this is really like the pill. It's the pill to prevent acquisition of HIV, as opposed to PEP, which is post-exposure prophylaxis, needs to be taken within 72 hours of exposure. And as healthcare professionals, we may have experienced this ourselves after a needle stick injury, but also NPEP, which is non-occupational post-exposure prophylaxis, can be given after a high-risk sexual exposure. So this, in this setting, tenofovir emtricitabine is given for 28 days, and so again, if we're following that pregnancy analogy, it's kind of the morning after pill to prevent HIV. So the efficiency of PrEP is really extraordinary, and numerous trials have been done in different patient populations. So in men that have sex with men, the names of the trials that have been done have been PrEP-X, IPA-Gay, PROUD. In heterosexual people, Partners PrEP and Tenofovir 2, and in people who inject drugs in Bangkok, Tenofovir. And the pooled efficiency of these studies in preventing HIV acquisition is 99%. So it is extraordinarily effective in those that remember to take it. So like any other drug, it doesn't work from the cupboard. And the PrEP failure cases in these studies, when serum levels of tenofovir are then measured, that the drug has been absent. So it works very well for those that are adherent to it. So what about the side effects of this drug? So there's mild transient headache, nausea, diarrhoea and fatigue is possible when the medication started, but I've never seen anyone have to discontinue drug because of those side effects, and they usually settle quite quickly. But more significantly, there's an issue with renal dysfunction. So uncommonly, tenofovir can cause a slow deterioration in renal function, and very rarely it can cause acute renal failure with Fanconi syndrome. So assessing renal function pre-prescription is really important. In addition, tenofovir can decrease the bone mineral density, but this is reversible after cessation of tenofovir. And as I mentioned earlier, tenofovir is used, and emtricitabine can be used to treat hepatitis B. So if that's present, it really needs to be managed in its own right. So that would kind of trump the management of PrEP and may change how we use the drugs in that setting. So identifying that infection at baseline is really important. So lastly, very rarely, resistance to antiretrovirals can occur if HIV seroconversion occurs. So around the world, there are about 300,000 people on PrEP currently, and there's a handful of case reports about HIV infection occurring in people with adequate level of the drug, so for those people that have been adherent. So this is why it's 99% effective, not 100% effective. And so, albeit unlikely, this is something that I do discuss with patients, and they can then assess their risk and consider the role of condoms in that setting. And if they're wanting 100%, then perhaps, you know, a belt and braces, condoms and PrEP may be the way to go. Most people probably don't make that choice. Oh, okay, so we need... Right, so what I've asked for you to have access to a copy to is the Australasian Society of HIV Medicine, or ASHM, has developed a PrEP decision-making tool, which is an A4 page with information on both sides, and it's the 5 steps to prescribing PrEP. So that's what we're going to step through now, the 5 steps being assessing for behavioural eligibility, for clinical eligibility, doing some other STI tests, and then prescribing and then monitoring. So we'll walk through that and then a couple of cases. And please interrupt me with questions along the way, if you like. I think it makes it far more interesting. So behavioural eligibility. So to know who it is we need to be targeting with this therapy, we really need to know in which populations the transmissions are occurring. And if we focus on the graph on the left, this is 10 years worth of data of the mechanism of transmission of HIV in notified cases in Australia. And you can see 84% there has occurred in the population of men that have sex with men. So that's really the group that I'm going to focus on, because we've got 20 minutes to discuss this here today. But the other smaller categories include male-to-male sex in combination with injecting drug use, heterosexual contact 10%, injecting drug use very small 1%, and then other. So when considering behavioural eligibility, it's in one of those boxes on the sheet in front of you, and I'm going to go in detail through the criteria for men that have sex with men, and not for heterosexual people, trans and gender diverse people, and people that inject drugs today, just in the interests of time, but please know that that is there on the sheet if it's relevant to a patient you're seeing. So in this table, the acronym CLAI stands for condomless anal intercourse. So if there's a person who within the last 3 months has had episodes of condomless anal intercourse with a regular HIV-infected partner who is not on treatment and has detectable HIV viral load, then that would be a criteria, and or receptive condomless anal intercourse with any casual HIV male partner in which the status is unknown. A rectal STI, such as gonorrhea or chlamydia, or a diagnosis of syphilis and methamphetamine use, and the anticipation that within the next 3 months these risk factors will be ongoing. So that is a group that is considered to be at high risk. And then medium risk, in the orange box there, anal intercourse when proper condom use was not achieved, where the serostatus of the partner was not known, or the partner had HIV infection and had a detectable viral load. And if the patient is uncircumcised, more than one episode of insertive condomless anal intercourse where the serostatus of the partner was not known, or again, someone with an infection with a detectable virus. And so I suppose when we're looking at these risks, we consider the efficacy of transmission through exposure. So this is a table of the likelihood of HIV transmission occurring per exposure to someone that has HIV and is not on antiretroviral treatment. I'm labouring this point a bit, and you'll see why in the next slide. So per exposure for receptive anal intercourse with the ejaculation, for example, is 1 in 70, and then the other risks as outlined on their screen. And perhaps I'll just highlight, because not everyone knows, but for receptive or insertive oral intercourse, we're unable to estimate the risk because it is so extremely low. Nick, did you have a question?
Just in regards to the reference to methamphetamine use?
Yes.
Qualifications around that?
I can expand on that, yes. So I think what that's referring to is methamphetamine use in the setting of sex. So this is commonly referred to as chemsex, but that does increase the risk-taking behaviour of people involved and would independently be something that would be making you think, hang on, this person's more at risk. Yeah. Yeah, we're good? Okay. So you might notice there's a group that I have left out in these slides, and that group is the people who are known to have HIV infection and who are on treatment and who have an undetectable virus. And that is because the risk of these people transmitting virus is absent. So that is something that is, a newer piece of evidence that has come to light through more recent trials. And the health promotion campaign that is advertising this message is U equals U, or undetectable HIV virus equals untransmittable through sexual exposure. And this is obviously in the setting of someone who is stable and adherent to their medication and has ongoing undetectable HIV virus. So that is why that group is not mentioned on any of the preceding slides, because if someone does have a partner who has HIV, who has undetectable viral load, well then that person doesn't need PrEP if that's the only person they're having sex with. So I just wanted to make that clear. So our second step is to confirm clinical eligibility. So the person needs to have had a negative HIV test within 7 days. And if there has been a high-risk exposure within the last 72 hours, then really we would be considering NPEP for that person. So the difference between NPEP and PEP in that setting would be we'd use more drugs. So we wouldn't just use tenofovir M-tricytidine, we'd use dolutegravir or raltegravir as well if there's that very recent high-risk exposure. And there is a proportion of patients who are diagnosed with HIV on their baseline test for PrEP, and they would need specialist care with an S100 GP or ID physician. So then we'd confirm that there's no signs or symptoms of acute HIV infection. Acute HIV presents much the same as any other viral illness, in other words, very non-specifically, with fever, rash, headache, lymphadenopathy. And we confirm normal renal function, so you have to have an EGFR greater than 60 and be mindful of other nephrotoxic medication because of the cumulative effect. So step 3, we do other testing in lines with the Australian STI guidelines. So screening with syphilis serology and also chlamydia and gonorrhea NAT on urine, rectum and throat swabs. And then hepatitis B serology. So sometimes laboratories, if you just write hepatitis B serology on the slip, they don't give you all the information that really you need to assess someone's hepatitis B status, and that's related to MBS item numbers in the lab, I think. But if you write on the slip hepatitis B surface antigen, surface antibody and core antibody, then you'll get all the results you need to accurately assess someone's hepatitis B status and know whether you need to vaccinate them, whether they're infected, or whether they've been previously exposed and don't have active virus. And hepatitis C serology should be included as well. And I mean, we're really talking about MSM population, but I've just put a tiny beta HCG down the bottom there. Obviously would be considered in other groups. So then, prescribing PrEP daily continuous oral dosing of tenofovir M-tricytidine is the standard recommended regimen. There have been a lot of studies about on-demand PrEP, but that's really not standard practice. That's not something that I do or we're doing in the clinic at this point in time, but it might change over time. Sorry, there's a question at the back. Yes? HIV, yeah, so that's on treatment monitoring. I'm going to get up to that if that's all right. I've got a slide in just a second if you'll bear with me. In fact, it's now. So that's the follow-up after we've started someone on treatment is described, and this table is taken straight off that page in front of you. So we've talked about baseline, reviewing someone in a month to check that they're taking the medications, they don't have side effects is definitely something we can consider. But other than that, it is really, really important that every 3 months that individual has an HIV test and other STI screening, because PrEP is great at preventing acquisition of HIV, but it doesn't prevent acquisition of syphilis or gonorrhea or chlamydia or numerous other things. So that's why that's part of the monitoring strategy there. And at each review, there's an opportunity to discuss, harm reduction and patient education as well. So now to a case study. Mr. M is a 36-year-old man who works full-time in hospitality, and he presented to the STI clinic because he'd heard about PrEP from his friends. He had a past medical history of treated syphilis, and in the last 6 months he'd had 5 male partners and was using condoms some of the time. So his last exposure without condom use was some 4 weeks ago, and he was unsure of the HIV status of his partners. But he himself had had an HIV test 1 year ago, and that was negative. So he didn't use recreational drugs, was not on any other medications, had been vaccinated for hepatitis B, and was not unwell. Oh, sorry. So we did the investigations as per the suggestions there with some serology, chlamydia, gonorrhea screening, and also renal function. So UECs, a urine albumin creatinine ratio, that is fine just to be a spot on a standard urine jar, so we don't have to collect 24 hours of anything. Don't do that, it'd be terrible. And also a protein creatinine ratio on the urine. And whenever I order an HIV test, I always advise someone to use condoms until their status is clarified, because otherwise we can get in the position where if someone's got an uncertain HIV test and we have to do more testing and we don't know what sex they're having at the time, it's all a bit awkward. So I'd always say, until we know what your status is now, I'd advise to use condoms. So I had a discussion with Mr. M about PrEP, and he was really keen, and he was understanding of the significance of adherence and wanting to do that. So critically, we need the HIV test kind of now. So as the PBS guidelines say, you need a negative test within 7 days. And we order an HIV test now, and in a day or so we have the result back. He's HIV negative, he doesn't have hepatitis B infection. He has a normal EGFR, and so he's able to start PrEP. So how you manage this, and how we manage this in our clinic, will really depend on the nature of the patient and how well you know them. It might be that you give them a script for Truvada on the same day as the discussion and say, I'll ring you tomorrow or the next day with the result, and then you can start taking it. Or you might say, no. Come back, in 48 hours, we'll check the results, I'll write the script, and we'll decide then. So that's a patient-dependent decision. So I like to review people in 1 month after starting them on a new drug, just to touch base and see how things are going, and then an ongoing 3-monthly review. The other thing I just quickly wanted to recap is the role of having an HIV test that is negative today. Because as you'd all recall, an HIV test has a window period, and with the modern testing, that's probably the window period of, 4, worst case scenario, 6 weeks. So it's really telling us the HIV status of the person, a month ago. So if a high risk exposure has occurred in that last month, then the test we do today won't be telling us about that. And I'll go on to talk about how we can manage that. So case study 2, Mr. N. He's a 25-year-old man who works full-time in IT, and he presented for an STI checkup having a past medical history of treated anal chlamydia. And in the past 6 months, he had 8 male partners, only used condoms with 1 partner. His last exposure was a fortnight ago, and this was in a sex on premises venue. He was unsure of the HIV status of his partners, and his last test was negative but 2 years ago, and he's intermittently using methamphetamine in the context of sex. So this is a kind of higher risk history that we're receiving. Again, no medications, vaccinated for hepatitis B, feeling well. So the investigations I've just outlined a few times, won't go through them. Again, this patient's keen for PrEP, really understands the importance of adherence, and again, adherence is something that we seem to talk a lot about, certainly in most of the clinics that I work, but I think with PrEP it's especially important. A discussion about methamphetamine and harm reduction. And again, all of his baseline tests were negative, but because he'd had that high-risk exposure a fortnight ago, we need to keep on testing him for HIV. So I would ask him to come back in a fortnight and do another HIV test then, and he can continue to take PrEP throughout this period, and again at 4 weeks another HIV test, and review at that time. And this is the idea of if seroconversion to that recent exposure is going to occur, we're going to catch it really, really early, and we will then manage his medication accordingly. After that, ongoing 3-monthly review. Oh yes, so that was to emphasise that point. So, in conclusion, PrEP really is now the standard of care in preventing HIV acquisition in Australia. It definitely can be managed in general practice. There's support available from ASHM and local specialist clinics, but I'd welcome any questions about this. Or HIV. This was we're doing it in halves. This is the HIV half, and then we'll go on to a hepatitis C half. So I don't know if there are any questions. Yes, in the middle. Look, it probably, I don't know officially, but I think it probably could. And so that would be why just that role of the history and ongoing testing to not miss anything. Yeah. At the back, yes? Oh, Tim. Oh yes, see I'm particularly fond of that test because in the renal tubule, that's where the non-albumin-like protein is filtered, and that's actually the area that tenofovir can affect. So albumin being filtered at the glomerulus is not usually part of the pathology for tenofovir-related renal disease. So actually I took it up with the because I did quite a bit of reading about this some years ago, and I took it up with some of the Alfred people saying, why aren't you recommending a protein creatinine spot ratio? And they're like, oh yeah, we're going to fix that. I said, oh, good. So, I mean, it's easy enough, we've got the urine specimen there, they can do both. I mean, it's good to have an albumin creatinine test, but that's why, because it's tenofovir affecting the tubule rather than the glomerulus. Yeah. Yes? Oh, of Truvada. So it's PBS subsidised. So for a non-healthcare card holder, the cost of a standard script, I think, is $36 or $37. And for a healthcare card holder, it's $6.20. Yeah. Oh, they should. I don't know. Yeah. But it's tenofovir tricytamine is no longer on patent. So certainly for the trials we were doing earlier, we were using generic drug. The name of that was Mylan. But this in no way has the price tags of some of the hepatitis C drugs, if that's what you were thinking of. But we're going to talk about that a bit more too. Yeah. Oh, Mike.
Hi. I think the cost is about $450, $460 a month.
Thank you.
Are there other dosing regimes being considered for NPEP?
No. So NPEP is always a 28-day course of therapy, and you choose either a 2-drug or a 3-drug regimen based on the level of risk. So the highest exposure. So if you saw a clinician who did exposure-prone procedures and they'd had a high-volume self-injection, that kind of stuff, definitely you'd be using 3 drugs. But perhaps there are some more recent trials I'm unaware of, but 28 days was what I have always done. And there's another question. Yes?
Have you got any data on the rise of the classical STIs since PrEP was introduced? Because
Yeah.
So some I have never seen, and then suddenly with PrEP,
Yes.
they don't use condoms anymore, so
Yeah.
all the other diseases are coming up.
There is no doubt that that's a side effect. Yeah. So I think that then comes down to how we counsel patients and risk management and the role of ongoing screening. But there has been an increase in the incidence of the STIs that are not in all other STIs. Yeah.
When you discuss side effects with patients, what do you
Yes.
go through with them prior to prescribing?
I don't really dwell on the nausea, fatigue, headache. Maybe I should a bit more, but it just seems to be so very transient and mild. So I don't tend to discuss that. And I say it's very important that we know this drug can affect your kidney health, and so it's important that we check it at baseline and continue to monitor it. I don't kind of do informed consent about Fanconi syndrome because I think the likelihood of that is so rare, and it's something that we would detect on our ongoing screening. So I think, the most time I spend on side effects is the role of what happens if you're partially adherent and you become infected, then you are more likely to have resistant virus. So that's probably the side effect that I spend most time talking about. And the patient population we see and give this drug don't tend to have high risk factors or have been diagnosed with osteoporosis. But because a bit of a different patient populations, but if there was someone with significant osteopenia or osteoporosis, then I think that would be something we'd have to discuss the risk benefits of as well. Okay. Oh, no, Simon.
So just with the PrEP, anyone can prescribe that with?
Yeah.
Yep.
Absolutely. Yeah. And actually, there's one more slide, and it was just talking about resources to assist with that. But as I mentioned before, it's part of the everyday work at the STI clinic at Bowen Health. So if there was someone you thought was at high risk and wanted a second opinion or assistance, we're more than happy to see people there. There are 2 halves to that clinic. So Mike and Bianca are kind of on the GP half, so obviously no referral to see an STI GP. And the other half of the clinic is staffed by infectious diseases physicians and trainees, and so a referral is required for that side of the clinic. Sorry, can you? Oh, with PrEP? For as long as one's at risk. So that would actually, thanks for asking that, because that can change over time. And I think that's the other role of the 3-month review, to see if the person still fulfills the eligibility for PrEP, because, people's, sexual behaviour can change for all sorts of reasons over time. So as soon as someone wasn't at risk anymore, obviously no need to take it anymore. But otherwise it should, coincide with the risk. Yeah. There was one last question. No, I don't think so. So the adherence in general is reportedly very high, and I think that there's a very high level of literacy about this in the relevant patient populations, and all sorts of discussions, and so there must be reinforcement of that in some ways. But no, we haven't found adherence to be an issue. Yeah. Yes.
Was a very occasional sexual sort of participant.
Risk taker, yep.
Could they say, well, I'm going to take PrEP this weekend, but
Yeah.
I'm not going to be having sex any other time for the next
Yeah.
month? Could they do it like that?
So that's the on-demand PrEP that I kind of referred to. So, yes, but that's not something that we're prescribing or recommending in a standard way. There's just less data to support that. And look, it probably does work, but until it's mainstream, I don't think in terms of enough data for it to be pushed into the mainstream, that I don't know that it's something we'll be advocating for.